Good evening. Thank you for coming. I'm Anastacia Wall. I am a physician assistant, and I am here to talk to you about neurologist-led team-based care of complex neurological patients. So, to start, I just wanted to show a study that was published in the Green Journal of the AAN Neurology about 3 years ago, which showed that in 2012 we would be having a shortage of neurologists to be able to provide services to patients around this country. So, and then because of the Accountable Care Act and patient access programs that are going on, we now know that that gap is going to be only expanding. So going from about a 12% gap to about a 20% gap by 2025. So the idea behind that is then to fill that gap, we need to train more neurologists. But even if we do so, and even if Congress gives us those spots, we still know that there will be a gap. Also, with the aging population and better diagnostic tools, we see an ever-expanding population of patients. Great, there it is. Okay, so you can see here that it is geographically based as well. That in the East Coast, you know, they have a surplus of neurologists, but then out in the western states you have fewer access to neurologists. Now this shows what will be happening by 2025 as the population increases. Then we will have even worse access to neurological care by that time. So as a PA, I would say that there is a solution. So that we can provide access to this care. We can provide high quality access for these patients. 11 years ago I made the best decision of my life. I became a PA. And right out of school, I joined and I became a neurology PA. So during a training as a physician assistant, so this is my school, University of Washington School of MedX, we are trained in taking a history, performing a physical exam, and evaluating patients and developing treatment plans, and then ultimately prescribing medications. I can, review imaging, looking at MRIs, and in doing so, I can provide services to these patients. So my first position right out of school was at a major metropolitan nonprofit hospital in Seattle, Swedish Medical Center, and it was a comprehensive stroke center that had over 14 telestroke sites at the time. And when I first got there, my neurologist had never worked with a PA or an APP, NP, and he didn't quite know what to do with me. And so then he said, well, let's just train you like a resident. So I was handed a pager, and I was told, here's your patient loads, or our patient loads. We're just going to see all our patients together. And that's what we did. We would round on these patients, we would see them, and over time I developed a comfort in seeing these really complex neurological patients. And side by side, we would review all the imaging, we would review their history, and then over time, he felt comfortable giving me my own panel of patients. And even in the hospital, I was the first down to the emergency room to then evaluate these patients. I was then, following up on these patients through their hospitalization, even through the neuro ICU, and then developing their discharge. We know that PAs, when they're studied, are found that patients like PAs. They like nurse practitioners, and they've been shown to give the same high quality care as other providers. So what really could have been a shortage of care, because on our service we would only have 2 MDs, and we would have either a PA or an NP alongside, and we would see 20-25 patients a day. And so that was a very busy service. So now, so this is a picture of the University of Colorado, so I'm practicing in a subspecialty now. And as an outpatient provider, patients are then screened so that I can see new patients. I don't see the person who has seen 5 other neurologists and still doesn't have a diagnosis and now they're going to see the PA. No. I see the person who has an established diagnosis, who is now looking to establish care. They need care. Or the person who comes through the emergency room and maybe they need to, it's obvious that they have MS, they have an acute demyelinating illness, they're not sick enough to go into the hospital, but they need a neurological care right away. My physicians are booked out 3 months. It's not uncommon. Oftentimes, the average is about a month around the country. And again, those times are only expanding. So what we've done at our center is now we're able to triage those patients appropriately, put them on the right person's schedule, and get that person a timely new patient appointment. I will see that person with my neurologist, and we together will formulate a good plan of action for these patients. And then, for example, that patient may need a follow-up 2 weeks later. I'll put them onto my schedule. I can follow up with them. I call them. My nurses. So this team-based care isn't just the PA. It includes nurses, physical therapists, speech therapists, occupational therapists, other doctors. We do case presentations. Oftentimes, even the neurologists, sometimes these patients at tertiary care centers can be really complicated, and it's uncertain even what their diagnosis is. But by working together as a team, we provide these patients with high quality, time appropriate care. So I just wanted to present one patient that I feel highlights this, my first patient that really highlights this what I'm talking about, team-based care. So this was a 38-year-old woman who had a long-standing diagnosis of multiple sclerosis, and she had suffered pretty severe burden of disease, but she was very stable for the last 2 years on a highly effective therapy called Gilenya. So she had been recently hospitalized for an acute exacerbation, received steroids, and stayed in the hospital for 3 days while she was recovering. She came to my clinic, which was the first time I met her, and she was still suffering from the initial problems that she was having. And so it was just about 1 to 2 weeks after her hospitalization that I was able to see her. When I saw her in my clinic, I couldn't help but to be surprised that she had a right hemiplegia and aphasia and also ataxia of the right side, which she was having difficulty with her balance. And I thought, she really just looks like a stroke. But she's 38, she has MS, and furthermore, she'd been seen by so many people throughout the hospitalization. Surely, so I pulled up her MRI. And as you can see here, her diffusion-weighted imaging shows an acute change, which can occur with MS, but it also shows ADC mapping, as well as no enhancement on the sequence with gadolinium. And then again, her flare sequence is not really showing any changes. Now that can be hyperacute, but this was a person who had she woke up onset with symptoms and then waited to present and then presented in the emergency room. So this wasn't the MRI that I was expecting to see. So still not certain. I talked to my neurologist. I say, we need to think about how we can help this person. I would like to do a stroke in the young workup in her. So that day was able to get her a CTA of the head and neck. I was able to get her an echo, and sure enough, she had an ipsilateral or same side lesion in her carotid artery that had showered off emboli and caused her stroke. So getting her onto secondary prevention right away, as we know, time is brain. The risk that she could have gone on to have a second exacerbation, plus giving steroids in this environment, if she would to get worse and have more steroids would not be helpful for her. So in this case, having a second set of eyes was very helpful, and for this patient, I believe, ended in a better outcome than had she been seen really by anyone else. So, my neurologist will tell you, my group of neurologists say, what is it that you like best about working with an APP? Well, they like the collegiality. They get to talk about their patients. We all like that. We don't like to work in silos. We like to work in teams. And in the outpatient environment, you're very much behind a closed door. So because I'm talking through my patients, they get a chance to talk through. I'm asking questions, they're learning about them, and we're really thinking these patients through. They're going through two sets of eyes, not just one, and I would advocate that this really creates a better patient outcome. Secondly, my patients, my doctors say, that we are dedicated and provide high quality care so that they can really provide the care that they want to provide. They want their patients to have good care. They don't like that they're booked out. They don't like that they can't see that patient back in 2 weeks. That's just the reality of their situation. And so I think that they love that they have someone coming alongside them who can really provide them with some help. So the next thing that I wanted to talk about was just a second patient, and I feel like this is the reason why I like having my neurologist. So this was a patient with neurosarcoid, okay? So she had not been diagnosed. She had biopsy negative in the lymph nodes as well as in the lungs, and nobody really knew what was going on with her. But following her longitudinally, we found out that finally, she had a diagnosis of neurosarcoid. And I was very glad. So in this case, this is not a patient that I would ever want to see on my own. This is a very complex medical patient. Because of her FLAIR imaging, meaning she had a lot of what are called T2 lesions throughout the brain, she could have had catasils. She also had headaches. It was very, very difficult to figure out what was going on. Now she was fully ambulatory, still working, but it was a tough diagnosis, and I really appreciate the skill and the long training that the neurologists go through in order to provide high quality care to these patients. But on this day, the neurologist wasn't in the clinic. On this day, the patient was seeing our headache specialist for her long-standing headache. And he said, there's just, you should come in and see her. She's just complaining of some things. I thought you should take a look at her. Well, I had seen her before, and so I knew that when I saw her sitting in one of our hospital wheelchairs, that this was not right. I examine her briefly, and I see that she has upbeating nystagmus. And so basically, I know I need to call a neurosurgeon. So I call the neurosurgeon, and they say, well, you need to get a brain MRI before we're even going to look at your patient. So we're not going to admit her until you have the brain MRI. I said, I don't need the brain MRI. I can see the patient. If you could see the patient, you would know it too. But so I did get the brain MRI, and as you can see, her fourth ventricle is big enough to drive a truck through. So she had a communicating hydrocephalus. She was presenting with a headache, a worsening headache, ataxia. I mean, she couldn't walk, and she was having a very difficult time. She was vertiginous, and she was going downhill very quickly. So after seeing this, it was with no small glee that I called back the neurosurgeon and said, would you take them now? And they said, of course. They shunted her that evening, and she was able to get care. So in this case, this patient was able to get that quality of care, even though she had seen a neurologist, because we were working together. That neurologist knows that I'm friendly, I'm nice, you can come to me, you can talk to me about anything. I'm happy, you can question my diagnoses, you could question, I'm grateful actually. If I can learn something, that's a good day for me. And if I can provide care to these patients, then ultimately I can go home and have a great rest. And speaking of going home, I love being a PA because, I have the work-life balance that I want. I'm able to get home in time, to be with my family, to do the things that I want to do, and I do admire the dedication and hard work of my neurologists. So this is where we are now. So right now I'm working at the University of Colorado. I'm working in the Division of Neuroimmunology, and we see probably 10,000 unique, we have about 4,000 unique patients per year, and we see about 10,000 follow-up visits per year. So it is a big service, and we have, I think, 5 neurologists and 4 advanced practice providers, or APPs for short. And with that team of 9 providers and a fellow here or there, we provide high-quality care to these patients. So in the stroke literature, we know that time is brain. We know that delaying care only promotes a bad outcome. If your mother or your father was suffering from Alzheimer's, Parkinson's, or nobody knows what it is, you would want them to have access to care. And we should be treating all of our patients, including those with government insurance, including those who don't have insurance, we should be treating them with the same level of care. So because PAs are paid for, so all major insurances do accept PAs and NPs. They do reimburse. Also, practices who hire a PA or an NP are finding that it's cost effective, that we can provide high quality, cost effective care, less of a cost of a neurologist. And these are patients that are going to need lifelong care. These aren't patients, it's different than neurosurgery, where they get their surgery and then they're done. My patients are going to be with me their entire life. They're going to need long-term follow-up. And in that case, a team-based approach is going to be the best medicine for them. So in summary, I advocate for team-based care, neurologist-led, but coupled with PAs and NPs to really promote high-quality, accessible care to patients in the United States. Thanks again.